Hi, everybody. Welcome to our webinar. We'll be getting started in a few minutes whenever a few more people get joined. So the last couple of minutes to nip to the loo or grab a cuppa and get comfortable. Good afternoon, everyone. Welcome to our webinar today. We are still having a couple of people joining, so we'll get started in just a little minute. But before we do, a couple of small housekeeping things. You have a chat and a Q&A function. So if you want to drop any questions in during Karen's presentation, and we've got some time at the end for some Q&A. So we'd really welcome questions throughout. Please put them in there. A few introductions. So I'm Dervla Mulholland. I'm head of clinical marketing here, and I am the moderator for today. So we also have Norma Finlay, who is our head of clinical operations. And Norma is a powerhouse and a tour de force of everything postural care and management. So we're delighted to have Norma with us, and our special guest presenter today is Karen Howarth. So Karen is from Neuro Rehab Physiotherapy, and we've got a really, really exciting presentation and really fascinating presentation that she's got lined up for us and prepared for today. So I think that's it for introductions, and a warm welcome, and we'll get started. Karen, over to you.
Thank you very much. So hopefully by the end of today's presentation, the words spasticity and dystonia might feel a little bit less scary. I'm a physiotherapist who's been qualified over 20 years. And even though I worked in neuro, I did tend to avoid spasticity because I tended not really to understand it. And that was until someone went on maternity leave and I got stuck in spasticity clinic, and I've been working in it for the past 15 years, which has been just wonderful. So hopefully by the end of today, we'll be able to identify more or be able to have an understanding about spasticity and hypertonic movement disorders. You'll understand in the wording a bit more and how that impacts on the ability to manage somebody's posture, but also how somebody's posture can impact on our ability to manage spasticity. And I am going to take you through some case studies as well. So the numbers are massive. And chances are, if you guys have been called in to do moving and handling or postural management on an individual with a complex posture, they will have an underlying neurological condition. And what we know is that 85% of individuals who have had a severe traumatic brain injury will develop spasticity. Around 93% of those with a spinal cord injury will develop spasticity, and around 85% of children with CP will have spasticity. So the numbers are absolutely huge, and because of that, we really do need to be considering spasticity right from the off. Now, I have been using the terms spasticity as I've just been talking now, and I'm not going to go through the next 3 slides in detail because I would rather talk more in detail about the case studies and that. But the term spasticity, it's a bit misleading. And if I was to say to you, what do you understand by the term spasticity? It would be quite an unfair question because there's absolutely no internationally defined definition of spasticity. So the only thing you need to get into your head when you're doing your assessment or treatment or planning is, does this individual have an upper motor neuron diagnosis? And that simply means, have they had an injury or an insult to the brain or spinal cord? If so, they could present with spasticity, and that just means tight muscles. It means that the muscles are working far too hard in one direction. So, if you think of your biceps and your triceps, what would ordinarily happen in the upper limb if you had spasticity? Your biceps would pull up. So, spasticity is one direction. You may have come across the term dystonia, and dystonia is a little bit more complicated than spasticity. Dystonia moves in all sorts of directions. So we can have what we call triplanar motion. So think back to spasticity, it's something that goes in one direction. Dystonia can go up, down, side to side, and it can rotate. And because of that, it can be slightly more difficult to manage. Alongside these two, we've also got rigidity. And with rigidity, we tend to get these with our Parkinson's populations or our cerebral palsies who have had basal ganglia infarcts. But you don't need to worry about the mechanism of injury. What you need to be feeling for rigidity is it going in both directions, and is that stiffness the same the whole way through? So spasticity, you can feel one direction. Dystonia, you can see multiple directions. Rigidity, you can feel two directions. So don't be afraid of using these words, but if you are, just use the term hypertonic. Hyper means too much and tone means tonic. Just say this patient presents with hypertonicity. That will cover all bases. On top of that, we've got an additional consideration, and this is something called hyperreflexia. This is the one that is always missed, and it tends to happen for our traumatic brain injuries and our cerebral palsies, and this is when they get that jumpiness. So if the engineer who's doing the wheelchair drops that spanner, they jump, or if someone closes the door too much, they jump. That is all part of the phenomenon of hypertonia. So I am going to use the term spasticity, but I will mean all of the terms that we've just discussed. It's just easier for the presentation. So why do we need to worry about spasticity and all the other things? Well, we actually only need to worry about it if it's causing a problem. And there's a lovely little booklet called the RCP Guidelines on botulinum toxin injections in adults. I'm a geek, and this completely floats my boat, might not yours, but this was last updated in 2008, and it's when all the clever people sat down together and thought, right, why is this troublesome? And what do these problems look at? And if you look at this little slide here, it's broken down into what we call impairment, activity, and participation. Now, this is how the World Health Organization classifies disability and disease. They break them down into these three sections. And the easiest way of remembering these, an impairment might be a sprained ankle. An activity might mean that person cannot walk, and the participation might mean that person can therefore not go to work. In terms of spasticity, they have specifically mentioned difficulties with posture, difficulty with seating, difficulty with positioning. So you guys and your job has already been thought of in terms of if you've got spasticity, your work is going to be so much more harder. And then we come on to this slide, which I apologize is extremely boring, but it's really important. And it might help you guys with your clinical reasoning. So like I said to begin with, spasticity can cause problems with postural management, but postural management can also cause problems with spasticity. If we think back to the impairment, activity, and participation terminology, and we look at this specifically in relation to posture and spasticity, if we start off here, body functions and structure, that simply means we've got a hypertonic muscle, we've got a spastic or dystonic patterning. What could arise from that is you could have increased pressure sores, contractures, and pain if the spasticity is not managed well enough. But in addition to that, if the posture is not managed well enough, and that could be seating, it could be sleep system, it could be slings for transferring. If that posture is not managed well enough, spasticity will increase and it will result in these secondary impairments of pain, pressure sores, contracture. If we think about activity and participation, and this might be things like the activity can they be positioned inside lying? Can they stand? Can they transfer? If they can stand and transfer, can they do that from their bed? Can they do it in a public toilet? If someone's got spasticity, it's likely that they will have a reduced physical capability. But also, if they don't have the appropriate postural management or moving and handling equipment in there, their spasticity will get worse. If we look down here at environmental factors, when I think about environment, I include splints, I include seating, I include sleep system, I include slings. If someone's got spasticity or dystonia, their tolerance of these aids is likely to reduce. But also, if those aids aren't quite right, aren't bespoke for that patient, the spasticity will increase. In addition to having the aids and the adjuncts, we also need to think about the staff who's implementing it. And this is completely your bag and not mine. And this, when I think about this, it always brings me back to a very recent case. So I picked up a gentleman who was discharged from hospital with a traumatic brain injury. No further rehab potential, hate that term, should be illegal. And he was discharged into the care of the community staff who discharged him very quickly, and we picked him up as a private team. When I went into his nursing home, he was issued with a Ray Azalea wheelchair. He had a flat cushion, despite the fact that he had a scoliosis and a pelvic obliquity. The wheelchair was 2 sizes too big for him. And the nursing staff, care staff in that nursing home were using a mobile hoist to get him in and out of this Ray Azalea, and they didn't even know that you could take the chairs off the legs off the chair. So it was an absolute nightmare. The environment wasn't managing his spasticity, and the spasticity was making the management of his posture worse. So we had a lot to do there in terms of environmental factors. And then we also have personal factors. What's that patient's choice? What is their voice? What is their goals? And we come along with our great ideas and our degrees, and we've read this in a book, and the literature would say this, that, and the other. But what that patient wants could be completely different. So this is the most important one, and I'm going to show you a little bit of a case study regarding that at the end. When I'm thinking about my global plan for my patient, I'm thinking about what is their tone doing and what is their posture doing. And I'm always thinking about these 4 things. So number 1, What improvements can I make? Can I reduce their tone? Can I improve their pain? Can I increase their range of movement? If I can increase their range of movement, potentially the postural aids they need will be less. Can I improve their function? Can I get them to sit for longer? Can I get them to stand more easily? I'm also thinking about what can I prevent? We know that if you don't manage spasticity well enough, that patient will end up with a contracture. The physiological makeup of their muscle structure will change, and that will be permanent, and no amount of pharmacological management will help that. Can I also prevent skin breakdown and the secondary comorbidities such as pain? Can I reduce the amount of equipment that this patient needs? Do they need that level of seating? Do they need that fancy sling? Or can I treat their posture and minimize what equipment and moving and handling they need? Because the less they have, the more successful it's going to be when us as professionals step away. And the other thing is maintenance. Now, maintenance is not a dirty word. We should be doing it. Every morning we get up and we brush our teeth. Every night we go to bed and we brush our teeth before we do that. Your teeth are no whiter, no shinier tomorrow compared to today. But if you stop brushing your teeth, you will get cavities. You will get holes in your teeth. And spasticity management is the same. It is something that we need to do for a long period of time. And once we stop doing that, the patient will deteriorate. So then if we now look at the treatment options, the Royal College of Physicians have produced this algorithm, and it's all right. It's it's good, but it could be improved. Um, it looks at the preventative measurements or management strategies that you can put in place, but it also gives you a bit of a hierarchy that we will talk about in terms of treatment options. But I would like to draw your attention to this section here, and this is generalized interventions, and they specifically say that postural management and seating and transfers and dynamic movement can all be part of spasticity management. So what you do is so important for that patient's global tone. If we then come on to treatment, these are the interventions that I would look at for spasticity management. So we've got the systemic pharmacology, and that basically means medicine that you either put down your peg or take in your mouth. We've got focal management, such as botulinum toxin injections, nerve blocks, etc. We can do surgery, and we can do physio and OT. Now, I am a physio by background, and we're good, but we're not that good. And the problem is with us, we've got these magic hands and we come in and we say, but I can get the patient into this position or I can get the patient into that position. There's 168 hours in every single week, and I can generally see my patients for one or two of those. What's happening those other 168 hours of the week when we're not there? We need to be thinking about what can last 24 hours a day when we are not there. And that will be systemic pharmacology, focal management, and postural management. This is a really important slide. So there was a guy called Novak, and he worked with his colleagues to do a systematic review of the randomized control trials of all of the adjuncts used to treat cerebral palsy. And they've broken it down into green, amber, and red. So a lovely traffic light system, very visual and easy to use. So if it's green, you should do it. If it's amber, maybe you should do it, maybe you shouldn't. We're not quite sure, or maybe we should be doing it, but there's just not enough background evidence to get into a randomized control trial. And red is definitely do not do it. What we can see up here for tone management, botulinum toxin. So when I'm talking about botulinum toxin, that does refer to what is typically known as Botox injections. Botox is a brand name. There are three brands, Botox, Dysport, and Xeomin, licensed in the UK. So I will refer to it as botulinum toxin. That is your frontline treatment for spasticity. That is what is evidence-based. More evidence-based than physiotherapy, more evidence-based than my magic hands, more evidence-based than a sleep system. That is what our patients should be having. And that is your evidence to go back to your commissioners with. Spasticity can be made worse by a number of things. And listen, please listen to the support staff. Listen to the families. We might be professionals, but they often will know better than us. If someone comes into your clinic or you go out and see them at home and think, gosh, their tone is, just going to pop that up, their tone is through the roof. The first thing you want to be asking is this their normal? Constipation is one of the biggest, probably the biggest contributor to increase in spasticity management. So don't be afraid to ask, when's the last time have they had their bowels opened? So, it's not been for a while. And then instead of thinking, oh, we need to send them for the botulinum toxin injections, actually, we need a bowel management regime in place. Any type of infection will increase tone. Posture will increase tone if it's not managed effectively, if they're having to work hard or they've got a lateral support stuck in against them when they're sitting up, or their head's dystonic and it's sticking into their sling when they are transferring. Look at all these things before we run and do the big stuff. So as a clinician, I was taught that we should take a history of present conditions. So what is your injury? How did you get here? Why are you in front of me? Then we should look at what are their other health conditions. So what's your past medical history? Do you have asthma? Do you have heart disease, etc., etc.? And then we asked about the drug history. And more often than not, we just wrote it down in a big list. And I know that there'll be clinicians on here today who continue to do that. I'm a non-medical prescriber, so when I look at a list of medication, I'm thinking those medications will indicate to me that that patient might have spasticity or dystonia or rigidity. And then I'm thinking, when was those medications last reviewed? Within my caseload, my pediatrics are being reviewed maybe once every 9-12 months. They're having growth spurts in between. Their medication should be increased. I've got so many adults that come out on 5 milligrams of baclofen and it's never reviewed ever again. Is it doing anything? Do they even need it? Or does it need increased? So instead of just taking that list of medication, don't write down something if you're not going to do something with the information. Have a look. When was it last reviewed? If it hasn't been reviewed, write back to their GP and say, please can you kindly review this medication? It's not been reviewed in 15 years. Do we need it? Do we not? Or their spasticity is through the roof. Please could you review it? We may need an increase. Or they've gone completely floppy. They're like a sack of spuds. Do we need it at all? And I appreciate that not all of you will be clinicians, and even the clinicians within you, not all of you are going to be non-medical prescribers. And this always makes me think about Victoria Columbier. So Victoria Columbier was a young girl who died at the hand of her aunts and her partner of child abuse. Now Victoria Columbier was seen by GP, nurses, social workers, teachers. They'd all seen her. They all could see what was going on in front of her. But it was a taxi man who took her to hospital. It was a taxi man who took her to A&E. Someone who didn't have the professional qualifications. Someone who didn't know what the signs and symptoms meant, but he knew something wasn't right. And he was the only one who did something. So don't think just because I'm not an expert in this area, I shouldn't be asking. It's not my place. They'll think I don't know what I'm doing. Just send that referral across. Just ask the question, because you could be the only person advocating for that patient. These slides will be shared. So this is a whistle stop tour, and I'm conscious I've got about 9 minutes left. These are the types of medications that you would see for each one of the impairments. And you'll notice that botulinum toxin is the one that's used across all of them. I'd like to draw your attention to diazepam. So many of my pediatric patients are on diazepam. The problem with any systemic medication used to treat global tone, so global means everywhere, is that tone isn't always global. The right arm isn't always as tight as the left arm. The left arm isn't always as tight as the right leg. And these medications do not have sat-nav. They don't go just to the tight muscles. They go everywhere. So what's happening is our patients can be loaded up with diazepam or baclofen, And these have side effects. The side effects are drowsiness, sleepiness, tiredness, fatigue, confusion. We're giving these children diazepam and sending them to school, asking them to crack on with their education. I'm then coming in as a physio and thinking, let's sit in a gym ball, or let's stand you up, and thinking, oh, why are they not doing so good? And it's because they are full of a systemic medication that's causing global weakness. Now, for some patients, they will need that, but for many others, we need to be thinking, is this the right thing to do? If we look specifically at baclofen, which is a really common medication for our adults, what we know is that baclofen lowers the threshold for epileptic seizures. How many of our patients have seizures? Lots. We know that if someone's on antidepressants, the threshold for baclofen to work will again be lower. We know that if someone's on baclofen, it can cause their blood pressure to drop. So as a physiotherapist, I'm coming along thinking, yeah, let's stand up, let's get you in a tilt table, and their blood pressure's dropping, and it's potentially because of this baclofen. So we therefore need to be thinking, can we go more focal? Can we look just at the muscles that are tight? And we can. And we do this with botulinum toxin injections. Like I said previously, Botox, Xeomin, Dysport, all licensed within the UK. They will tell you that they do slightly different things. In my opinion, they all do the same. It has to be injected into each individual muscle, and it causes relaxation of that muscle for around 3 to 4 months. It then has to be repeated. And it's just like taking paracetamol. You take paracetamol in the morning, you have to repeat it 4 hours after. The issue is with Botox is people say that it doesn't work. Now, if you put it in the right place for the right reasons, with the right shared goals and enough of it, it'll work. In addition to that, what we need to be asking is, was ultrasound used? So we use ultrasound always. And if your patient goes off, has botulinum toxin injections, and you think, didn't do what it was supposed to do, it might be because they didn't use ultrasound. It didn't end up where it was supposed to. There's evidence to say that you get 96% accuracy with ultrasound and 39% accuracy without. I would not go to a dentist who had 39% accuracy. And if you do have injections, patient does have injections, it'll take around 2 weeks for the injection to kick in. We'll see a benefit for around 6 to 8 weeks, and after that, things will start to taper down. So you want to be doing your assessment at around 2 to 4 weeks. That's prime time for you guys to be doing it. If you do it at 6 weeks, they're at 6 or 8 weeks, they're at their best. And when that starts to wear off, whatever you've prescribed might no longer work. Nerve blocks are also injections, and what happens here is you get it's like an alcohol injected around the nerve, and instead of doing one muscle at a time, this can knock out a number of muscles at one time. In my experience, I haven't seen it work as well as botulinum toxin injections because they are more specific. So my recommendation is some patients will need systemic pharmacological management. Absolutely, they will need that, but we need to be thinking about the side effects. Are they standing and transferring? Is that really difficult? Is their blood pressure dropping when they do that? Do they not have enough muscle tone to keep them upright? Is that increasing care burden? Can we go focal? Can we just treat the problem at the heart? So if we look at some case studies here, this is a really typical presentation for somebody that I would treat. We've got the left shoulder internally rotated and adducted, so it's pulling across right into that lady's thorax. This was taken in 2024 in the UK. This lady was known to NHS services. This lady has a grade 4 pressure sore along her ulna because her spasticity was so tight, she was pulling into her rib cage. It was so preventable, completely negligent. So we injected up around here, we injected her elbow, and we got her fingernails out of her palm. I've had patients whose fingernails were growing into their palm. You might think that's not your issue because you're dealing with slings and sleep systems and postural management. If someone's fingernails are growing into their palm, that is producing a pain stimulus. That pain stimulus is increasing their global spasticity and causing a moving and handling nightmare for you. You need to refer back to the GP. Put your hand up and say, please, can you do something? By doing those injections, we were able to get the arms out, which meant that she could then be sat better. We could actually get lateral supports in her. With the lateral supports in place, she could sit for longer. She was less fatigued. And it's just thinking about what else can we put in the wheelchair for that. Um, this is a teenage lad. And as you can see here, we've got wind sweeping. He was no longer accessing his standing frame. He was a full body hoist transfer. And this was the best positioning that we could get. His popliteal angle was 90 degrees. We could barely get his leg out any further than that. So the issue was knee flexion and adductor tone. What we did there was we injected the hamstrings and we injected the adductors. He was then, after one cycle, he was able to cross leg sit. He was able to re-enter his standing frame. If he can stand, bone density improves, bladder and bowel management improves, blood pressure improves. And that was after one cycle. He will need orthopedic hip surgery as well, but can we manage the pain until he gets there? Can we keep him on his feet until he gets there? This is the same little lad, and we had an issue here with the elbow and the wrist. Botulinum toxin's a drug, and there's only so much that we can give. So we had to think about which is the bigger problem, and he had skin breakdown on his wrist. One cycle of injections brought his wrist from minus 80 degrees to about minus 20. So he had reduced pain. He could get his coat done. Getting his coat done and getting him out to school was an absolute nightmare. And what was lovely about this, we got him a splint after his injections, and he maintained that range past the 4 months, which meant that the next time we didn't need to inject the wrist, but we could inject the elbow. When we injected the elbow, we found no improvement, and that told us that there was contracture. We then referred him to an upper limb surgeon to get that released. So if we look at this little lad, if you were just to go in and stick a T-roll in there, chances are he would end up with a pressure sore on his knee, or he wouldn't tolerate it, We wouldn't wear shoes that were too tight. Put yourself in the patient's position. But with the injections, loosen everything off, improve his comfort, reduce the pain, he would accept a T-roll, and it would absolutely be the right thing to do there. When I come back to patient choice, this is a lady who had vascular dementia. She had multiple areas of spasticity. She had a pressure sore on her neck. She had a pressure sore on her ear, and she was just a big bundle of tone, and automatically I would have thought systemic medication. However, she was standing up with her husband. She was palliative. She didn't have much time left. And her standing up and doing that transfer, if we had given her systemic medication, she would have been looser, definitely, but she would have been more fatigued. She would have been less able to follow instruction, and that transfer would have become more difficult. Do I think she should have been standing and transferring anyway? Absolutely not. But that was their personal choice. We've got this little lad, and you'll notice the hoist in the background here. So he was previously walking with the assistance of a walker. But the issue here was his feet had flipped out into this posture because of tone in some of the lower leg muscles, and he could no longer get his splints on. If he put his splints on, his skin broke down because of the posture and because of the spasticity, and because he couldn't wear his splints, he could not be hoisted. He could not, or sorry, he had to be hoisted. He couldn't stand. We injected his perineum, just 2 cycles. He got his splints back on. He got back up on his feet. He didn't need the hoist as regularly anymore. He still needed moving and handling support, but he was able to do something for himself. So I think that is my time up. Hopefully it was a whistle-stop tour. There are more slides here that you can have a good look through, but hopefully that was useful.
Yeah, thank you so much, Karen. That was excellent. Really, really, really interesting. Um, a reminder for anyone who joined maybe a little bit late. So we're taking questions either in the chat function or using the Q&A function there. So if you want to drop in any questions, Karen has 10 or 15 minutes to take some questions. So the first one was from Alex George. Can we get a copy of the slides and a recording? She was having a few issues with Wi-Fi. So I think you'd said that you'll make the slides available. So we'll
Yeah,
send that all out in the follow-up. And
yeah,
there will be a recording available as well. So
yeah.
so thank you for sharing your slides there, Karen. Um, Norma has asked, how often do you need to complete a cycle to maintain the functional benefits of Botox? And is it routinely available via the NHS?
So, in terms of the NHS, it is a complete postcode lottery. So, I've just stopped teaching because I have no more time. This I teach injection therapy at university, and we have delegates from Northern Ireland, Scotland, Kent, London, Midlands. We had delegates from everywhere, and it's a complete postcode lottery. So, I'm in the northwest of England, and if you live in Preston, you'll get your injections done 3 monthly. If you live in Liverpool, you're going to get them done 6 or 8 monthly. It's a complete postcode lottery. And for me, it's people need to be asking for it. We can't just sit back and think, that's just how it is here. If you prescribe something to assist with moving and handling, when their tone is not managed and then it's suddenly managed, you prescribe the wrong thing. It's going to become obsolete. So people need to be noisy and vocal and ask for these services. In terms of how often does it need to be repeated, it's very patient dependent. I've got patients who, if it's not done every 3 months, they will develop pressure sores. They will come off their feet. And I've got patients who I'll do 1 or 2 cycles. They're absolutely fine. They may have a growth spurt and they come back 6, 12 months after. So very, very individualized.
Great, thank you for that. Quite a few people just saying thank you and excellent content, really engaging, well delivered. So thanks for that. A couple of other questions then. Do you encounter parotonia?
Paratonia. Can you explain?
Um, well, I can give I'm non-clinical, but
Yeah,
my understanding of parotonia is an involuntary resistance to movement. So, for example, someone with dementia, quite often they will, if you're trying to help them get dressed or put their arm in, they'll pull their arm away, and that's actually an
yeah, yeah,
involuntary movement rather than a deliberate conscious
yeah.
thing.
So if it's to do with dementia, that is a brain injury because they are presenting with strokes, infarcts, etc. So they will be presenting quite often with rigidity. Rigidity more so than I would say dystonia. And with these types of patients, it would go back to the list of medications that we would use for rigidity. So your levodopas, um, that kind of thing. But yeah, your toxin can work for that as well.
Mm. So Sabine has said lack of funding in our patch for Botox and community for bedbound patients. They used to have access to a neurology consultant to perform home visits, but all of these seem to have fallen away. Have you any suggestions how we can get these patients seen? I guess that's
Ye-
back to the region by region approach.
You need to be noisy. You need to be really noisy. When I worked in the NHS, we had Datex forms, and no one really wanted to put an incident form in or a Datex form. But if you can see that someone's level of function has deteriorated or they have presented with a pressure sore or they are needing more pain medication or their care burden has gone up because their tone is not managed, you put an incident form in and you do it again and again and again and again. And you reach out to the commissioners. I found the best way to get through commissioners is to put a patient in a big wheelchair in front of them.
Yeah, that can definitely be a powerful demonstration for
Yeah,
sure.
yeah,
High muscle tone we experience in our dementia patient. Yeah, that's correct. Sorry, that's just somebody
yeah.
clarifying the parotonia.
It's just not a
Uh,
term that we tend to use because we tend to use
yeah,
the rigidity and the spasticity. What I would say with that as well is I'll quite often write that this patient presents with a mixed pattern of spastic dystonia and rigidity. They don't have to have one or the other. Um, and I think the term that we would more commonly use is hypertonia. Yeah.
yeah. How can we educate care teams on the benefits and need for pharmacological strategies?
I actually did a project on this within the NHS, and I literally went into each care home and did a bit of a presentation around when the GP comes in, can they review that baclofen? Does it need going up? Does it need going down? But then working with the care staff as well. When you are moving and handling this patient, do it slowly. Do it confidently. When you're bringing those legs apart to get that catheter in, do not be wrenching them apart really quickly because that's going to make the tone shoot up. So it's going to be a combination of speaking to the nurses and thinking, are we actually reviewing this medication? Can we get a minimum of a 6 monthly annual review in place? But working with the carers themselves to discuss these are your triggers, the tone's going up, have they got an infection? I've got patients who would regularly present with a UTI, and the first time we know that they've got a UTI, their tone goes up. So you can backward step as well. If someone's tone goes up, dip their urine. You can treat the infection quicker. So it's very much trigger management and handling and positioning. Increase that base of support. Do everything slowly and confidently with the support staff.
Okay, the next one then, Fiona. In prescribing Botox, would you typically look to manage one issue at a time, or would you look to Botox all at once?
It depends on the presentation. Sometimes you just never have enough Botox. So, like that image, the images that I showed you of this little lad, where is he? Because we were doing his lower limb and his upper limb at the same time, I didn't have enough toxin. So, what we did is we immediately referred for surgical intervention. And we were thinking about what other adjuncts can we use at the same time. Um, if you do have enough injection, enough dosage, I would try and do all of the movement patterns because we move in synergistic patterns. And if you treat one thing and you don't treat the other, you could end up with a bigger problem. And that's why when we're teaching this, I feel that the physiotherapists have a better understanding about movement and biomechanics and synergistic patterning than the consultants do. The consultants might be better with a needle, but it's the assessment that is the really, really important thing. So if you've got enough dosage, treat everything. And if you don't have enough dosage, you've got to be thinking about what other adjuncts you can put in place.
Uh, Another one here then, is there an exclusion criteria for who doesn't get Botox injections?
Um, Very, very, very few. It tends to be the more rarer neurological conditions, things like myasthenia gravis, that you wouldn't eject those types of conditions. But anybody with traumatic brain injury, cerebral palsy, um, your dementia type patients, they should all be able to access it. Very, very few.
A couple more questions coming in here just before we wrap up in about 5 minutes or
Sunshine.
so. Uh, so this is a long one from Stephanie. She apologizes for a long message. No need, Stephanie. I work in the care home sector where I try and support with these cases and provide workshops to homes on how they should deal with it. I joined to gain more knowledge on making referrals to GP for pharmacy support. Would you suggest that I suggest to care home staff that they should only be working with a therapist if referring for pharmacy support? I'm conscious that the homes will refer on for Botox, etc., but no therapy support. Do you make sense?
In an ideal world, you would have therapy. In an ideal world, you would have physio and or OT to come in and do the stretches and put the postural management things in place. And that's the ideal world. So the answer should be yes. However, if you've got a patient who, for example, who's got really tight adductors, they've got spastic adductors and they're pulling in, um, if you can get some Botox injections into those adductors, we know that those legs are going to come out. And it goes back to the point of the physio and the OT can be there maybe 1 or 2 hours a week. Once that's injected, it's in there 24 hours a day, 7 days a week for 12 weeks. And we know that that will be working. So it will be doing something. Um, so I think the answer to the question is ideal world with unicorns. Yep, have your therapy team as well as your pharmacology, but some form of spasticity management is going to be better than nothing.
Um, and Stephanie's also requested to get your contact details
Yeah,
so that she can get in touch directly. I know you had your email address up on the slide at the
yeah,
very start. I don't know, maybe if you want to put that back up again, Karen, and
yeah, will do.
we'll include that in the and when we send out the slides in the follow-up email as well. Um, there's one more of a point than a question, but I'll let you answer it if you wish, Karen. So
Yeah,
Charity has said it's important to say that if muscle is already too shortened and contracted, botulinum won't work. But often you don't know until you've tried the Botox.
exactly. And that's the point. So we've had quite a few recently who've the NHS have completely refused to inject. And we've said, well, we can do it, but it will be an assessment. So we do our measurements of tightness and um, catch and range of movement beforehand. We do measures like carer burden, how easy is it to get those clothes on, catheterize, etc. We'll do the injections and then we will repeat the outcome measures. And sometimes you might not even get any more range, but the tightness and the resistance within that range reduces and the carer burden reduces. But yeah, sometimes you just genuinely don't know is it contracture or is it spasticity until you inject. But you've just got to be very, very clear with your patient and their caregivers that this is an unknown and that we may not make any gains.
Okay, well, I think that is all of the formal questions there. I suppose just one final question from me, Karen. What would be your one key takeaway that you would like everyone to go away knowing or thinking?
Do something. You don't need to have all of the answers. You don't need to know the terminology. Is that muscle working too hard? And if it's working too hard, is it causing a problem? And if so, get a referral to the GP. This patient is presenting with high tone. Please can you refer for spasticity management and physiotherapy?
Excellent.
That's
Well,
that's all you need to do.
I think that's a lovely way to wrap it up. Like I said, we'll send out the follow up with all of the details that we've talked about there. And I suppose it just leaves us to say a huge thank you to Karen. A lot of people have gotten a lot from that. Lots of good feedback there for you. So well done. Great
Very
job.
welcome.
And I'm sure people can reach out to you if they want to find out more about the work that you're doing and
Yeah,
how you can help them.
yeah, no problem at all. Anytime.
Great job. Well
Take
done.
care. Bye.
Thanks, everyone. Thank you for joining.